Sure,
Humana
sure.
folks.
So the work group is really spent a lot of time addressing the problems and challenges of the people that participate in the work group. So it's self-directed, democratic, and we've made a lot of success helping for a couple of years now on the traditional sources and uses of data enabled by interoperability. And some of these challenges are well known, and some of the changes underground are pretty significant, but we've helped with transitions of care analytics, et cetera. And we continue to do that into next year. However, last year it was determined that, you know what, there's some new sources of data that are being used. So we spent time on genetic data, social determinants of health, imaging, patient-generated health data and reported outcomes. Terrific. Double-clicked on social determinants of health. So that's what we're doing this year. Go ahead, Claudia. And so we've actually had quite a few wonderful sessions on things ranging from the role of HIEs in sharing social determinants, categories of data and coding schemes, and we'll hear much more about that today, so looking forward to it. The role of telehealth and virtual care, and we got into this even before COVID accelerated these efforts, so that's another aspect of it. How you have to, it's really not about just the data and the organizations, but how collaboratives can utilize this data to capture and make a difference. And last one we had was on converging technologies, was fascinating. If you couldn't see it, go get it from the website. But it really is, it's not one technology, but many. It's HIE and telehealth and image exchange and analytics and incorporating SDOH. Pulling all of that together is really what is making folks successful with it. And we hope to get to policy issues as well. So, but without further ado, I would like to introduce or pass the baton to Caraline Coates and Stephanie Franklin, who are going to really share some interesting perspectives. It's really hard to utilize social data if you can't grip it, if you don't know where it is, if you don't know how to identify the transactions and pull the relevant data out. So we're going to hear some interesting perspectives on that. Thank you very much.
Sure. Thank you. This is Caraline Coates with Humana. I'll assume everyone can hear me. Okay. I'll speak slowly in case people can't. Okay. So I have a personal conflict. I'm just on audio right now and not on the video. So I'm going to kick this off a little bit and then turn it to Stephanie Franklin on my team to go through the slides. So just as a little background. So I have a strong passion and interest to combine and kind of marry the worlds of value-based payment with what do you call it, social determinants of health or health-related social needs, right? In a lot of ways, I used to lead our value-based payment strategies. And so from a Humana perspective, we are kind of at the point of the evolution of our value-based payment models and looking at ways to integrate incentives for clinicians to screen and refer and connect members to the right community-based resources to address identified health-related social needs. And I think when we first started down this path, it sounded a lot easier than it really is. And I would just share that, you know, so we're learning. We've got about a dozen contracts off the ground right now. And intentionally going slow so we can learn the insights from this before we scale more broadly. But I think at a high level, you know, some of the key learnings is that, you know, until we as an industry have standardized processes for capturing social risk indices, if you will, as well as standardized coding to identify, to code, to bill, as well as reimbursement, and all those things. Not to mention, in parallel, a community-based network that is sustainable, right? That can capture and accept the referrals to address these needs. It's going to be challenging to really marry these two worlds. That's not stopping us, so we're trying, and I will go through kind of our learnings and what we're doing in this model and speak to the importance of trying to get to a more standardized place so we can scale this. But with that, and I don't have the slides, so I know there's a lot of kind of intro slides on this model and what we're really trying to do. I'll turn it over to Stephanie, and I'll just end with that. A lot of our work in the Office of Population Health for Stephanie and I is around testing all sorts of interventions around all different health-related social needs for the purpose of getting results that can essentially ignite and create some momentum for establishing a social risk index and for modifying the way plans get paid so we can downstream payment to providers differently and structure benefits differently, right? So there are a lot of different work streams that I think are really important to go in parallel right now, and we'll focus on the value-based payment model a little bit, but just recognize that's one spoke on this wheel. So with that, Stephanie, you want to walk us through the slide?
Sure. Thanks, Caroline. That's perfect setup, because I wanted to start with giving kind of the broader picture of what the Bold Goal team and what Humana are focused on, and why we even care to collect and analyze these SDOH codes. So go ahead and go to the next slide. Really wanted to highlight here that Humana is really focused on integrated care and whole person care. You can see that social determinants of health are one of the key pillars of what we do. And it is really integrated. It's part of how we're meeting the whole health needs of our members. And all of that is powered by technology and by data that allows us to understand the risks and the needs of our members. So and go ahead and go to the next slide. So Caroline and I are both on the part of Bold Goal, which in 2015 Humana declared this big aspirational bold goal to improve the health of the communities we serve by 20%, actually by 2020, so by this year. And that really set us on a journey focused on population health, and not just focused on individual medical needs, but really on the community and social context that our members live in. So we measure this progress towards our bold goal using Healthy Days, which is a health-related quality of life measure developed by the CDC. And there are a lot of pieces to it, and you'll kind of see a little bit of a preview of it, but it's really, we've really honed in on social determinants of health as a way to improve health-related quality of life, because we can see that these are the factors that are influencing health, or influencing the well-being of our members and affecting their downstream health outcomes. So on the next slide, you can see our currently 16 Bold Goal communities where we have gone deep with community partnerships, collaborations with physicians on the ground, key health systems, as well as many community health organizations. You mentioned HIEs earlier, and we can get into health information exchanges and social health access referral platforms, as we call them, but those sort of the infrastructure and of community organizations that are working to meet the social health needs of the residents of those communities. And so on the next slide, this is, we really have evolved from a community-based relationship on the ground to address the social needs of our members within the community context. And now we've really scaled to SDOH is just part of our business model. We believe it is that fundamental to the health of our members. So you'll see a few things on here that Caraline already mentioned. So really at the core of this is the SDOH care continuum. identifying those members that are at risk of a social barrier, treating that social need as if it is a clinical gap in care through some sort of intervention. So whether that be a benefit that we've been able to offer through new flexibility granted by CMS, or through a closed loop referral to a social service agency, it's really about bringing these social needs into the whole health picture. Underlying that, we really, you can go back. Underlying that are, of course, the data that we need to identify, not only identify who's at risk, but also to measure if a gap was closed and the success of that. We rely heavily on having a network of community resources, community partners that we can connect our members with, connect providers with, so that they can also address the social health needs of their patients. And all of this, kind of filters up to understanding what works and scaling that and incorporating it across everything we do. So whether it be our benefit design, integrating it into integrating it into payment models. So, and that kind of gets us to the value-based care model. Really, if we consider social determinants of health to be one, just as important as what happens in sort of medical care as far as health outcomes. If we want to treat clinical, medical, social, and behavioral health kind of as all equal components of health, we really need to make sure that we're incentivizing to do that, and aligning those incentives towards the outcomes that we want. So now you can move forward to the and go at one more. So we're doing this in a lot of ways. Really trying to, you all know this piece, which is that it outside these social and community barriers to health, having access to healthy food, transportation, and some sort of social connection impacts health outcomes. And we know that a lot of our members are impacted by these. We know because we screened a lot of members, and we've done that through our care management programs. We've known it through just surveys of our members, all of which has kind of fueled our data ecosystem and allowed us to build new analytic models, predictive models, so we can anticipate who is at risk of having one of these social needs. But it is, but a few things. We can't screen everybody, and we really want, it is important, we really want to integrate this into what happened, how physicians are caring for their patients. So go ahead and go forward. Yeah. But resources are really misaligned to do this. So what we've intended to do through our value-based SDOH model are to align resources. Hello?
I got a second. Someone has their audio on. Hang on.
Just someone put us on hold or something. So through the SDOH value-based model, we are directly incentivizing physicians to screen for social needs, to document those in the medical records using SDOH codes, and then connecting patients who have needs to the appropriate resources. We have physician partners in our local markets and across the country that are in different parts of the spectrum and of how much they integrate social needs into their practice. But we really, we believe it is important, and we really want to provide an incentive to more, to build that into just the way that we practice. And you know, with this also, a huge bonus of this is that, as you all likely know, SDOH medical codes are not very frequently used right now. They're not reimbursable, and you know, we've looked in our medical records historically, and I know CMS has put out a report recently for the fee-for-service population, and it's just a very, very few records actually have what are these SDOH ICD-10 codes, the so-called Z codes, attached to them, and so what that's actually the specific codes that we are asking physicians to, or healthcare providers to document in this case, and hopefully this will not only change the routine, but also help us just get more data in about what barriers our members are facing. So, and allow us to also learn some things. Caraline mentioned that we are starting kind of small on this because like I mentioned, every group is a little bit different and different part of their journey and maturity in the way that they can do this. So our team is working really closely with the providers to build to build the models and to make sure that they have all the resources and tools that they need in order to be able to screen and document and refer. So we'll be learning, does this incentive create behavior change? Do we start to see more screenings, more codes coming in? And when we see that there is that full kind of continuum is met, where there's a screening, a coding, and some sort of intervention, do we see improved health outcomes? Because, you know, that's really a big, while we have some good evidence, what's really still a gap is, does addressing a social need directly impact health outcomes? So this is hopefully going to help us kind of fill in some of that missing evidence. So that was a lot. I think, is there another slide? Yeah. Claudia, do you want me to pause for questions before I move on to kind of some of the other things we're doing with the data?
Sure. Does anybody have any questions? I know some people submitted some questions ahead of time, and we can go through those afterwards. But if anyone has a question now, just to sort of set the stage before going forward, anybody?
I would just like to ask, this is Al, how well received was that request of, hey, you now have to screen for other things? And I'm sure some embraced, some resisted, and some were neutral, but just, you know, any anecdotes or what was the initial reaction?
And I don't know if Caraline is still on and has anything to add for that, but what I will say is that we have not imposed this model on any provider groups yet. I don't know, I say yet, but we haven't imposed it on any provider groups. It's really been part of an ongoing conversation that Humana has had with these groups. We already know that they have a common interest in learning into the space, no matter where they are in the continuum. They already are interested in the impact of social risk on health outcomes, and want to partner with us really to advance their practice and advance our shared learning in this space. So it has been definitely, I think it has taken longer to get some of these set up than they thought they might take, just because of the nuances in each relationship and each provider group. but and again, where they are on that kind of maturity model. But in every case, it has been part of a willing partnership.
Great.
Hi, this is Andy with Intersystems.
Hi.
Hi. How long has this program been going on? Is it relatively new, or?
Yes, it's relatively new, and that's why I will not be able to share any actual outcomes from it yet, unfortunately. Most of the contracts kind of went live on July 1st, so we're still just in the
really
early
new.
stages. Yeah.
Yeah. And hey, Stephanie, this is Caraline. I'm sorry. Go ahead. I was on talking earlier. I was on mute, but sorry. I'll add to what you said. But go ahead. Finish your question. I didn't mean to interrupt you.
Yeah, I was just going to ask, did you provide the care providers with like a list of questions to ask? Everybody would sort of be asking the same 5 questions. You're checking on the same 5 indicators, that sort of thing, kind of limit the scope of what they would be asking about, but also give them someplace to start from?
Yeah. Yes. So they're all standardized screening questions. So they're asking them in the exact same consistent standardized way, so we can compare those results. And then back to the providers, though. So we actually have a lineup of providers who want this, and because we're learning about it, right, we're struggling a little bit from a resource perspective. So in no case are we asking anyone to do this. This is more, well, we're asking, but we're doing it based off of interest. And it's interesting, right, where some providers have the infrastructure already and they're screening for social determinants of health, and they're all on board, and there are others who don't really have it, but they also recognize the importance of it and they kind of want to learn. So I'd say the demand right now is greater than what we can, not what we can support, but I just think because we don't have the results yet, right, we don't want to do something where we haven't leveraged the learning. So it's a very much of a partnership kind of relationship with the providers. And in all cases, it's where they already have an existing, to Stephanie's point, value-based agreement with us. And this is kind of a logical next step in the evolution of their arrangement. But it's mostly, because Stephanie, keep me honest on this, the screening questions mostly around food insecurity, social isolation, and transportation. And those are all anchored in industry standardized format questions.
Yeah, I think some also include housing issues.
Yep, that's true.
All of those areas, there are validated screening questions that are being used, and in most of those cases, there is an SDOH Z code that is appropriate for a positive screening. We can have a sidebar on the current coding set in just a minute, but the way that they are screening and coding is consistent across the models.
Hey, Stephanie, someone in the group, Carly, wants to ask, do the questions come from standard assessments, Prepare?
Yeah. So they're not Prepare, but yes, they are standardized screening questions. So it's kind of a mix. For food insecurity, we use the hunger vital sign, which is a 2-question screening. For loneliness, it is the UCLA 3 loneliness scale. And then the transportation and housing questions are from the Accountable Health Communities health-related social needs screening tool developed by CMMI. So they are all validated screening tools for those domains.
And then let's do, Ronnie has a question, and then, maybe finish your slide presentation and we'll go to the Q&A. Ronnie wants to know, do you also screen for income, wage level, and employment status?
Not in this model, no. These, and Caraline, correct me if I'm wrong, if you're still on.
Yep, I'll be on for about another Medicare, 5 minutes.
Oh,
but
okay.
Yep.
All of these are Medicare Advantage, or are they across lines of business? Yeah.
Nope, this is all Medicare Advantage for right now. Yep.
Yeah. It's not exactly a commercial or Medicaid business. So but so we did not include those right now. We also have some pretty good proxies for income and wage from in our current data that we get from CMS, whether or not a member is a dual eligible member, so could be a dually enrolled for Medicare and Medicaid, as well as the Part D low income subsidy. So we have pretty solid data on at least those aspects of income for the Medicare population.
And the idea here also is to, I want to say, that's to arm the providers with a process to screen for some of the health-related social needs. I'm not going to say that are easy, but that maybe there's a higher capacity within the community-based organization with which they could refer to address, right? So things like food and transportation and loneliness is harder, but I mean, there are more and more solutions out there. So I think that's where it becomes important to start to differentiate a little bit more what's in a health-related social need or social need bucket versus a deeper root cause determinant, right? So employment status and access to education or some of those things that this is hard, right? Many providers will say they don't think it's their responsibility to address the social health needs. And if you read deeper into some of those articles, it's not that they don't want to, it's hard, right? The data to diagnose and the resources to treat, it's all very fragmented. And so I go back to kind of what I said at the beginning, until we can standardize those more, it's not really fair, in my opinion, to ask providers to treat it. So we're trying to start with something that is a little tangible, that if they do identify someone who's positive for food insecurity or loneliness, that there is access to resources in the community to address that. That will then, longer term, show itself up in improved outcomes and quality, right? So.
Thanks, Carolyn. So Stephanie, you want to finish the deck and we'll go to video then.
Yeah, sure. I did want to make say one thing about the specific codes, and again, I don't know how. This seems like a pretty nerdy group, but I don't know how deep you want to go into specific types of codes, but the ICD-10 codes are one source of SDOH data, and that's what we have built into the value-based model. We are aware that there are other types of medical coding, and we are actually part of the Gravity Project, and we're one of the sponsors of that initiative, which is seeking to standardize the codes for social domains and across the care continuum. So not just at the point of diagnosis, but to be able to really document the full process of when a screening took place, the response to the screening, the diagnosis of need, and then the outcome, the intervention that happened, which as we get further into this that will give us such a rich source of how the screenings are happening, and if the gap was closed, that is something that we're also cognizant of, and is further on the next level kind of maturity as we seek to integrate SDOH codes more broadly into our data and the way that we work with physicians. So I think we mentioned a couple of times this idea of social risk adjustment. Right now we have both in the way that managed care is paid for through MA or through a Medicaid MCO, that usually it's clinical risk that is considered. There are a few demographic things like age and disability status that can be considered in that sort of medical risk, but if we all acknowledge that these social and behavioral health needs are also contribute to health outcomes, we really believe that these should be also considered into how we look at the population and how we manage manage their risk and how we consider our payment model. So we have, if this is not yet so much based on the SDOH codes, it's based on a lot of our other data, but we'll be, you know, as we get more and more of the coding in, we'll be able to leverage that as well. And, you know, we've already built a social risk index off of the screenings of our members, which will tells us at an individual level the magnitude of their social risk. We're already integrating this into a lot of our clinical models, and using that to sort of elevate and draw attention to those members that, you know, might have the same or somewhat lower medical risk, but have a higher social risk, therefore more in need of, maybe in need of some sort of outreach intervention. Okay, so going forward, I think this is the last slide. So anyway, this is kind of just sums up what we kind of talked about. So I'll go ahead and stop there. You know, with that last piece of measuring outcomes, we're not quite there yet, as I mentioned, because we are still very early in this process. But as Caraline mentioned, there's a lot of interest. There's more interest in participating in these models than we even have capacity to work on right now, and are ready to. But it's very promising that there's a lot happening in this space. So happy to take any questions about all what we talked about or about other pieces of our SDOH strategy. Oh, now I get to see all your faces. Okay.
That's
Stephanie and Carolyn, that was
absolutely
fabulous.
fascinating. Claudia, do you want to go through some of the questions that were submitted? You want me to? I don't care if you got them handy.
You know, we'd asked people to submit some questions, and we've got several. But I was just wondering before we get started if there was anything from anybody right now that they'd like to ask, and then we've got all the other questions that we would definitely like to go through. Anybody with a question for Stephanie or Carolyn right now?
Hi, this is Rani. My question was, you know, how have the providers managed this from a time standpoint? Is there an extra, you know, effort? I mean, I shouldn't say effort in the sense of they may have to build in, let's say, an extra 10 minutes or something into their appointments to do this. So is that something you guys have talked to them about before, or how are they handling this?
Yeah, I'll take a stab at that, Stephanie. So I don't know the actual, I think the time's going to vary by provider. So you've got some that have been doing this. They've got the social determinant of health module built into Epic. They've got kind of a process to do it. And others are learning and trying to figure out how to make it most efficiently. It's fundamentally built around, we're paying them an incentive to do this, right? That we're kind of sending the message, we believe in addressing the health-related social needs are that important that if you do it, if you take the time to do it, one, we're willing to pay you because we think it is going to show up in improved outcomes and cost, you know, reduced costs and all of that at the end. Now we haven't proven that yet, right? We'll see. So, so there's a little, I can't underscore the importance of trust here, right, between payer and provider. So there is they're having to change their processes and build in a little bit more time, but we're also saying we're willing to pay you for it because we believe in it. We'll see what the results look like. So it's in choosing the provider to do this, it really is important that they also believe in this to find the time. But I don't have an answer for you on it takes X amount of time. It does vary by practice and the infrastructure and sophistication that they have. So I don't know, Stephanie, if you have anything to add to that.
Well, I will add one very practical thing and then one broader comment that, you know, these providers are already in value-based arrangements, and that the intention is to help them to be able to spend a little bit more time caring for the whole health needs of their members. This is just an extra incentive and support to make sure that social needs are included in that. The other thing about these SDOH codes, they can be, it doesn't have to be the treating physician that codes for them. So it can be another clinician who's on the care team. So that also is a way that these codes give a little bit of flexibility to the practices.
So Stephanie and Carolyn, we've got a question from Lee Burchell. The question is, do you find that patient trust is a factor in this topic? For example, a patient feeling intruded upon if a question is asked about employment status or behavioral health history, domestic abuse, etc.
I'll take a stab at that also. So I'd say there's sensitivity around these questions with patients with members regardless. Right. So that's, yeah, short answer is yes. I don't think this model magnifies that. But it is why I think it's a great question, because I think it's, while we're testing this model here between provider and patient, it is not the only place where we're asking these questions, right? Because of the sensitivity, and trust is really important. And the provider in the clinic office is often not the best place to gather this information. So we're arming nearly every associate who interacts with our members, might be the pharmacist over the phone, that can get that information better. So that is it's a great challenge that I think is just inherent in our industry and world. And so yeah, yes, it is, and where you have the more mature value-based relationships, and they've had the same members for a while, which I think the learnings within the Medicare Advantage space are going to be not necessarily always applicable to other where there's less years of retention. But when you have 7, 8, 9+ years between provider and patient, that trust is deeper. And so some of the discussions around these are easier, and they can kind of be gateways to some of that. But it certainly is an issue and does vary from provider to provider.
But I will add that this isn't our model per se, but there has been some research on this, and I was trying to very quickly find it, and I think it was the special American Journal of Public Health edition that came out last year, but I could be wrong.
Hey, Stephanie, while you're doing that and looking that up, I'm just going to use it as I do have to jump off right now, so I didn't want you to ask for me if I wasn't there. So my apologies for having to leave late, but you are all in really good hands with Stephanie. So appreciate the opportunity. I'm happy to field questions or have any discussions if anyone wants to contact me directly after this. So thank you.
Thanks, Carolyn.
Thanks, Carolyn.
All right. Okay. Bye.
Bye. Yeah, so I was correct. So there were a couple pieces of research published in the American Journal of Preventive Medicine last year. It was both a quantitative and a qualitative study of social risk screenings and patient acceptability. And I won't. I'm going to just probably poorly summarize their findings, but essentially, overwhelmingly, the patients were not only accepting, but welcomed having their physicians ask about their social needs. People tend to see that as critical to their own health and well-being, and they want their physicians to know what they're going through or what barriers they're facing, rather than just talking to them about what medication they need to be on. There was some hesitancy about documenting it actually in the medical record, but it was still the majority of patients were okay with that. So if you're interested in the patient trust factor, that might be something to look at. Okay.
Hey, Stephanie, there's a question from Russ. Hey, Russ, does the clinical care team include the MA, the medical assistant?
Yes, I believe so. That will depend on the particular provider group, probably, but as far as the coding goes, they're included.
And the last question on the chat is, have you tried to connect this with the annual Medicare screening visit?
Yes. Yes, we have. And I don't have the findings of that. I think we obviously want you know, we encourage physicians to screen for social needs. You know, we haven't really set, I don't know that there's a firm frequency, but we have experimented with tested adding the questions to that screener. It's already very long, so I think there's been some resistance there that it's kind of already a very long visit, and most Medicare Advantage members are in the office twice a year, but yeah, so we have. So.
Thank you. Al? Oh, Al's on mute.
Yep, no, here you go. So
There you go.
there's a couple of them that I thought were interesting. Mapping the prepare tool used in Epic to ICD codes, or encouraging Epic to build their module to do so, was just one of the questions that a couple people have hinted on. And so it wouldn't, let's not just make it Epic. Let's just say the EMR vendors in general, encouraging them to have this capability embedded.
So we mentioned Epic specifically before because Epic does already have a module built out that it is based on Prepare for the most part, and already has kind of the logic for the codes built in. But we have worked with other vendors as well to kind of, and a lot of them have sort of an SDOH module, or you can build your own, or they can build one for you in there as well. So I guess it just depends on the vendor, but Epic does have like a standard one built in.
But
you have to pay to turn it on.
You'd be willing to work with a vendor that was in your portfolio of you know, locations to do so, correct?
Mm-hmm.
Okay. And then another one is the ICD-10 code's going to be directly linked to Snomed. You hinted on this. You said that you know, the codes that you're using are used in other vocabularies and vernaculars. So what's going on there? What do you think will happen?
Wow. I mean, I think in an ideal world, as we get social health more integrated, you know, we will be asking providers to code more along that continuum using the Snomed code, which would be great insight into what actually happened. Right now, one of the ways that we are going to get that sort of outcome, the intervention, what happened there is some of the providers are just reporting back, kind of more ad hoc, and then some are part of kind of a closed loop referral network like a Unite Us, if you've all heard of that. And so we'll be able to look in that system if a referral was made and a gap was closed. So that's an exciting new tool that we're really supportive of and trying to support in all of our goal markets at least. But going back to the specific code, so you know, part of the process through the Gravity project is to kind of do a huge inventory of all of the codes that are out there, map them to a specific step along the continuum of care. They've already finished food insecurity, so if you're really interested, you can go and look at. They've mapped all the screeners out there and all the potential outcomes and all the potential interventions, and then they're identifying the gaps. So they're making recommendations to the various governing bodies to add or adjust. An easy one, and I mentioned there are some limitations to these codes, that right now there isn't an ICD-10 Z code specifically for food insecurity. It's lack of access to food and clean water, essentially. And that makes really good sense probably in an international system where you might have, you know, or in some rare occasions. But for us, we really want to know, is it food or is it clean water? Because those are two pretty different situations. So like those are the type of, there are a lot of recommendations like that will be being presented and hopefully will be integrated in the next couple years.
Okay, great. Here's another one. Are you guys, and you hinted on this as well a little bit, incorporating the SDOH screening into your, hang on, they just left, into your risk stratification. And it sounds like that's a future, is that correct? Or are you already doing so today?
Yeah, so we are, I will say that we've been doing a lot of work already to develop predictive analytics to help us identify those individuals at a higher social risk. But coming later this year, we'll be launching our first work to actually use our social risk index in the in like our rostering engine. So to actually stratify it kind of overall as far as members identified for clinical care management. So we're very excited about that, to get that off the ground, because it really does show the sort of the evolution and you know, in the industry, but also in Humana, for those of us who've been working in the space for a long time, to finally get to the place where Humana is also going to start using this data to stratify and outreach to members for clinical outreach. Is really great progress.
And you did mention before that the timing of it is such that you know, as people move down the path, you'll get more information. You'll be able to better use it. But it is nice to at least know the puck that you're skating towards. The thing that I liked that you said was the SDOH that are health related and fixable, right? So let's not waste time acknowledging a whole bunch of things that may be terrible for an individual or terrible even for a sector, but you know, you want to have the impact you can to help the biggest population. So it's how you segment that population that will help you be successful. Okay. We have a question from Kay. I am a HEMA certified coder, and the provider does the assessment and the screening. We assess, assign, and review the codes. What about dietitians for over and underweight?
I'm going to say I don't know. Over and underweight are actually a clinical diagnosis, so that is not in scope for this work. We've really honed in on the actual SDOH codes. So I will plead just ignorance there.
Okay. How do you see the standardization of SDOH terms and codes progressing over the next several years? You've sort of touched that a little bit, but maybe, you know, since this is such a broad group and people are in so many different areas, perhaps what needs to be done to accelerate that process a little bit.
Right. Yeah, absolutely. I mean, just the terminology where everyone uses, from, you know, social determinants of health, which can be everything from like structural racism to not having access to you know, transportation access to get the grocery store. It you know, can be a really broad catch-all bucket. At Humana, we've increasingly shifted to talking about health-related social needs, because most of our work, like the value-based arrangement, value-based program, is focused on identifying individual members who have social needs and helping them try to address those. And as I said before, kind of treating these social needs as clinical gaps in care that we can at least try to help address. We've developed a lot of tools and resources and benefits for us and for the physicians that we partner with to help address those. But you know, we still, you find us talking frequently, find us talking past each other based on like what we're talking about and what is that level of intervention. Is it some sort of major policy change, or is it delivering meals to a member who doesn't have access right now because of the coronavirus? So all of that is to say that I think the Gravity Project is really leading a lot of that sort of standardization of the coding and some of the nomenclature that goes along with that. And I think that'll be really helpful. And that, you know, even you know, I agree. Standardization in the terminology is very much necessary, and I think just so we are all speaking the same language, and probably just more communication is really what's going to move that as we hone in about what we're really talking about and what part in the at what part in the continuum that we're referring to.
Sure. And then
yeah.
do you see gravity potentially helping us get there? And do you make a call for more people participating so we get some critical mass and, you know, the right committees doing what we need to do?
Absolutely. Yeah, it is really a consensus-based process. Right. So, you know, as many voices and stakeholders are participating, it makes it just all the more richer and the more complete. So if you are not engaged and you have any sort of stake in this at all, I encourage you to get involved. The meetings are open to any participating folks, and everyone has an opportunity to provide feedback on it. And it already has a lot of support from, you know, like medical associations and parts of the federal government and other payers. So it really has a lot of steam behind it. So.
Sure. Guilty as charged. I've heard about it. I've read a little bit about it, but I and everybody on this, you know, work group should probably at least find a way to contribute from their perspective, or it won't be as successful, and encourage others to. So then at least one more, lastly, how do you feel about the policy and privacy sort of fall in the face of progress? And you mentioned it in your last comment, but if just getting your arms around, you say talking past people, there's so many stakeholders with so many perspectives, just to be able to isolate the policy or privacy issues that a group like EHI can and should be addressing, not just for SDOH, that's too big, but just from a coding standpoint and from a use of those codes. Do any pop out at you, or how do you think we'd even, you know, go about trying to identify and isolate what those are?
Yeah. You know, some of the barriers to this sort of social health infrastructure that we talk about of, you know, really pulling in new providers, new partners into the care team. So these social community-based organizations and social services, you know, we speak different languages, both in terminology, but also in like coding we use. Like there are codes that the homeless information systems use that won't speak to medical codes. So that's going to be something that we're going to have to work on. But on the privacy side, you know, setting up these networks, even if it's a closed network, even if there's any sort of referral to a social service agency, you know, there's so much confusion. What's a covered entity? What can be shared? What should be shared? How do we get feedback? What can be shared back after something has happened? For, you know, you know, there is a way around it under current law. It just takes a lot of attorneys and a long time to really get to an agreement that everyone is okay with and comfortable with. And I think that is something that we're going to have to continue to work on and communicate with the regulatory agencies on, so that they can help us get to the place where, you know, we can work with small nonprofits without burdening them with huge attorney's fees in order to just refer a patient to them.
Sure. So in the clinical information exchange, at least before we liberated the data electronically and made it easier to share, there were some norms about what clinicians did and didn't share. Mm-hmm. When you start going to the social determinants of health, I don't know that those norms really exist between those organizations or between social organizations and clinical organizations to set as what is the foundation at which we want to put policy around. So, you know, whatever your organization, because you have a lot of lives within your world, could do to help isolate what those either existing norms or future policies would be great. So,
Yeah.
and this work group is looking to maybe have a session on those issues. I don't know if we'll be able to get it done this year. If not, maybe next year.
Great.
Any other questions? I did quite a few from what was provided. Any last minute questions?
This has been fabulous, Stephanie. Thank you so much. Really appreciate your expertise and time and willingness to stand alone and respond to all the different questions.
No problem. My pleasure. Thank you for the